I'm going to get going, I think. So welcome everybody to our Pharmacy First webinar. I'd like to welcome everyone who's on here from Thames Valley area. So those that have pharmacies in Oxfordshire, Buckinghamshire and Berkshire. Welcome and thank you for joining. I just want to say that we have got our chair on the call. So welcome to Robert Bradshaw.
Hi, good evening, everyone. Thank you for coming.
And we also have James Famikin, who's our vice chair. Hello, James.
Good evening, everybody.
Ian Dunphy, who's the treasurer.
Good evening, everybody.
Hi, Ian. Kevin Barnes, who is our contractor support officer.
Good evening, everyone.
I can't see any more committee members at the moment. Okay, so we'll get cracking because I really want to get the sort of the up and running with the slides. So we've got plenty of time then for any questions that you may have around the service. And this is primarily aimed at pharmacy owners. For those that maybe haven't read the full specification yet, or those that have but have more questions, or those that are sort of have half read it or heard something about it, just want to learn a bit more. So we've been sort of on many meetings over the last sort of 6 weeks or so. So hopefully any questions that you may have, we can answer them here. And if you don't know the answer, we'll take it away and we'll speak to Community Pharmacy England or the NHS or whoever the question is best answered by. So let's get going. So pretty much the presentation is something we've put together to give you a sort of the context for the service, why we're doing the service in the first place. It's important to understand where this started and where it's going to. A summary of the requirements of the service, a little bit about the clinical pathways and PGDs, not a lot of detail because this is something that if you're a pharmacist, it's something you've really got to take on board yourselves and really immerse yourself in the detail. But we can help with that little bit of learning development updates that the LPC is offering, CPE is offering, CPPE and clinicals. And what you need to do to prepare to provide the service. What are the sort of administrative requirements or physical requirements? And I think through the course of the presentation, we'll touch upon some of the do's and don'ts really around the service. If you do want to ask a question at any time, just drop something in the chat, and my chair Robert and CSO Kevin will make sure they're answered by the end of the presentation, or maybe be able to answer them in the chat room itself. But we'll have a bit of time for Q&A at the very end. So why are we talking about pharmacy first? Well, the NHS and Department of Health and Social Security put together what's called, we call it the PCARP. It's the Primary Care Plan for Recovery, basically. Mainly, obviously GPs get a lion's share of the focus on this, but there's a lot that we can do in community pharmacy to give patients better access to healthcare services. So Pharmacy First is part of that. But you mustn't forget that some of the money that's been put into this is also for increasing access to the pharmacy contraception service, hypertensive case finding service, and there's a fair bit of money, about £20 million, going into the IT infrastructure, which is well overdue and much needed, from what we've been doing with other services in the last couple of years or so. So just going to talk very quickly, only one slide on each. So the expansion of the contraception service. So extra money's gone into this because the money basically within the global sum just wasn't enough. So some money has been added to the pot to make it viable for us to deliver it as a service. There's a lot of encouragement to use your pharmacy team mix to actually deliver the service. And they really want a lot more contractors to sign up. You may remember when it was first launched, there was almost like a standing order from CPE. And we echoed it that there wasn't enough money in the pot. Don't sign up for the service because all you're going to do is drive down the dispensing fee. But now there's extra money in there. We're actively encouraging you to sign up. And they've also added a function within the NHS website so patients can actually find out which pharmacies are delivering the service. So, please sign up for the service. We've only had something like 25% of pharmacies in Thames Valley sign up for the oral contraception service at the moment. I know it can be a little bit complicated to understand the safeguarding, the clinical aspects of it, but I really do encourage you to sign up. And £75 million outside the global sum has been added to make this really worthwhile for you to deliver. We've had a really successful hypertensive case finding service. And again, we're encouraging more pharmacies to take part and actually to conduct far more blood pressure checks, and especially the more diagnostic ABPM check. You may know now that other pharmacy staff can now conduct the BP check. So we're actively, again, with £75 million extra funding, actively encouraging more pharmacies to sign up for the service. And in fact, we have got about 80% of our contractors are already signed up, which is really good. We're delivering something like, I can't remember, Kevin. It's is it a couple of thousand a month now? BP checks across the patch?
Yes, it is. It's about that. I'm trying to think of the exact figure now.
Yeah. And a lot more in some pharmacies.
Yes.
So let's go into pharmacy first then. So this is a new advanced service. It's incorporating the old CPCS, the one that you've been delivering for 3 years now. And that's going to be replaced by Pharmacy First, but the service is split into 3 elements, really. We've got the new element, which consists of all the clinical pathways. You've got the urgent supply of repeat meds and appliances, and that was already in CPCS. And then you've got referrals from 111 and GP practices for minor illnesses. So the 2 boxes on the right-hand side, they're existing, and the new part of it is on the left-hand side. So Pharmacy First, if you do opt in, if you do register, and I'm pleased to report that 90% of all the pharmacies in Thames Valley have registered, which is really encouraging. It's one of the highest in the southeast. If you do sign up, you have to provide all 3 of the elements. It isn't a pick and mix. It isn't you've got to do all or nothing, basically. Now, the big change around this is for the clinical pathway side of it, is that patients can just walk in and present themselves with one of those 7 common conditions. And we'll talk about how that works later on. Clinical pathway consultations can be provided remotely, but only by high quality video link. And DSPs can provide all of the pathways remotely, apart from earache for 1 to 17-year-olds, because you need to obviously do an examination with an otoscope. So there's no other changes basically around the rest of the service, the old, what we call CPCS service. But obviously we're actively encouraging GPs to continue those referrals, and in fact to increase them substantially to make sure you constantly get the income stream that you need. So when we talk about the clinical pathway consultation, what am I talking about? So basically, the service spec's been put together, and it includes what we call the 7 common conditions, the 7 clinical pathways. Now, this is where it gets a little bit overwhelming for many. There's 23 associated PGDs to go alongside the 7 clinical pathways. And because there's 1 PMed, there's also a clinical protocol as well. So, we'll talk in a little bit what you've got to do with those. The clinical pathways contain 1 or more gateway points. So for a patient to be eligible to receive the new Pharmacy First clinical pathway consultation, that gateway point must be passed. So this is sort of a simplified version of a much more complicated flow chart that appears in the service specification. This presentation will be going out to all of you. We'll put it on our website as well. And I've tried to put links into all the relevant websites where I can. So later on, you'll see lots of hyperlinks. So if you think about the left-hand side where we've got referrals, this is basically what you've been doing already, except for if a patient meets the gateway for one of the 7 clinical pathways, then you would conduct the new Pharmacy First consultation. And one of the options obviously would be then to dispense medication based on the PGDs. If a patient is referred and the gateway isn't met, you deal with them as an existing CPCS referral patient. Now, for all that left-hand side, you receive a payment of £15 per consultation, plus other pots of money, which I'll go into a little bit later. So even if the gateway isn't met on the left-hand side, you still get the £15. You don't get 2 lots of £15 if they come in for a referral and then it moves into a clinical pathway. It's one payment of £15. On the right-hand side, though, if a patient just walks in and say, well, I've got a sore throat, can you look after me? If they meet the gateway criteria based on the top half of those clinical pathways, they move in to the Pharmacy First clinical pathway consultation. Whereas no matter what the result is, then you still receive your £15 referral fee. Although, if they present themselves in the pharmacy and they don't fulfill the gateway criteria, it's then treated as an everyday walk-in patient, and they could receive self-care advice, whatever, but there is no payment for that patient. That's part of your current pharmacy contract as an essential service. So there's no change to that bit if they don't meet the gateway criteria. So what do you need to deliver the new Pharmacy First service? Well, you have to have a consultation room, and I think we have got a consultation room in every pharmacy in Thames Valley. And don't forget, they do have to meet the terms of service requirements that you signed up to with your contract. And that includes having access to IT equipment in the same room. The only piece of mandatory equipment you need to deliver the service is an otoscope, and that's only for the acute otitis media for 1 to 17-year-olds. And there is buying advice within the specification. So it has to be UKCE marked, MHRA approved, has to be 3 times magnification, manual focus in a hard case, and you should be able to replace the tips as and when you need them. I think many of you have probably already bought otoscopes or used otoscopes in the past or for other services that you already deliver. You must have an SOP to deliver the service, including the process for escalation. And I'm sure you've all got access to somewhere where you can get SOPs or where you can use an existing one and adapt it for this service. There is no mandatory training for delivering Pharmacy First, but there is a level of competency that's needed to be safe in delivering this service. And I'll go through some of those sort of frameworks that you can use to check your competency. And obviously, there'll be some training requirements around safeguarding, the ones that you should already have anyway. You must be using an NHS assured clinical IT system. So Cegedim, Farm Outcomes, Sonar, Positive Solutions that help you sort of report the consultation, send a message to the GP and get payment. You need to sign up using MYS, and we'll talk about the timescales for that in a second. And where you do supply an NHS medicine, the same rules apply for normal prescription charges. So if a patient is exempt for a normal prescription, they're exempt for a Pharmacy First medication as well. Hopefully all that's clear. So funding. So I talked about the original pharmacy primary care recovery plan. That came with £645 million, and some of it we've spent, like I said before, on oral contraception, hypertensive case finding, and IT. So the balance then has gone into the Pharmacy First service. So if you sign up before the 30th of January, and it's the 30th of January, there's no option to extend that. It's the 30th of January, drop dead date. You will get paid £2,000 as an initial fixed payment. That will not change. That is non-negotiable. If you miss the 30th of January date, you can still sign up, but you don't get your £2,000. If you've already signed up by the 31st December, you should be getting the money next month as part of your reimbursement. And if you claim by the 30th of January this month, you'll get paid on the 1st of March this year. The payment, though, will be reclaimed. So this is a very sort of subtle change to some of the other services that we've had, where pharmacies have signed up, taken the setup money, but not delivered the service at all. So this time, if you don't deliver 5 of the clinical pathway consultations in the first 2 months, they will claim the £2,000 back. Because basically you're saying, well, you've taken the setup fee and you're not delivering the service. There's also going to be some thresholds per month, which you need to deliver to get an extra payment, which I'll go through on the next slide. And for every consultation, you'll get £15. And the fee for the current CPCS service has gone up to £15 as well, as from the 1st of January, in case you didn't know. So you'll also attract an extra payment of £1,000 a month, as long as you deliver the minimum number of clinical pathway consultations as shown in the table on the right-hand side. So, for example, in February, we're expecting just one clinical pathway consultation from each pharmacy that's signed up. If you do that, you get £1,000. But in March, you've got to deliver 5 to get your £1,000. And of course, by the end of March, you would have had to deliver 5 in total to keep your £2,000. So now you can see throughout the year, it's going to get higher and higher and higher until it gets to October, and it'll be 30 consultations a month. So don't forget, this isn't consultations in total across the whole of Pharmacy First. This is just the 7 that come in for the clinical pathways. As you can see from April, there's going to be a cap of 3,000. So don't get scared by that number. That's put in there because don't forget DSPs, so Pharmacy to You, Boots Direct, Lloyds Direct, etc., they can also deliver the service. So they've put a cap in to stop them doing 20,000 a month or 30,000 a month, because don't forget, Pharmacy to You are delivering, what, 1.7 million scripts now. So that's put in there to rein in the DSPs a little bit, because I think they're still looking for a quality consultation from your community pharmacy. And what they'll do then in October is have a review based on the number of consultations done, but the target is to deliver 3 million a quarter across the whole of England. So that's 12 million appointments saved from the GP a year. That's an awful lot of appointments that will stop going through GPs and start going through community pharmacies. And that's where there's going to be a shift in income, hence the £645 million needed to pay for the service. So let's just cover quickly the clinical pathways again, a little bit more detail this time. So the clinical pathways element, they've been designed to sort of help manage the common infections that you get that will be presented in community pharmacies. So they're not just looking for medicines to be dispensed, they're looking for self-care and safety netting as well. So even if you don't dispense, you still get your payment, as we've talked about before. And it's a very restricted set of medicines. So you can complete an episode of care for those common conditions. The NHS have used SPS to put together the PGDs and the protocol, and they've all now been published and signed by the Chief Pharmaceutical Officer and the National Clinical Director for IPC and AMR. So a lot of people, a lot of brain power, a lot of medical know-how went into the design of the clinical pathways. And you may have seen it already where we've had a little bit of pushback from primary care in GP practices, from hospitals around the whole antimicrobial sort of stewardship of dispensing antibiotics. Well, these guys who designed the PGDs, some of them are leading AMR sort of clinicians in the country, and they're confident that community pharmacy will do the right thing for the patient, and it's not a license to over dispense antibiotics. In fact, there's research out there that proves that once an antibiotic goes into a community pharmacy, the amount of prescribing goes down, not up. And we've seen that with local services around UTI already. Community pharmacy is brilliant at stewardship of antibiotics. So, every time I have a meeting now with a GP or a clinical director, I always reinforce the fact of the protection we've got put into place around antibiotic prescribing. Now, obviously, the NHS is going to look very closely at the data that comes through the Pharmacy First service. One of the reasons is for antimicrobial resistance, so they can sort of tweak it if needed. And they're also working with NHS BSA to check the reimbursement mechanisms and the supply of medicines using PGDs. And they're also going to commission an evaluation of the whole service. What they haven't mentioned on this slide, actually, is that they are going to continue to do post-payment verification on community pharmacies, just to ensure that there's nobody out there that's maybe taking things one step too far and abusing the system. And that's there to protect everybody else, actually. I think it's a good thing. And you may have seen some stories around lateral flow tests and pandemic delivery services where it's been abused by just one or two pharmacies in the country. Okay, this is a picture of one of the clinical pathways. And at first sight, it looks rather complicated, but it's a fairly easy to follow flowchart. So the first part at the top, before you see the yellow triangle with the red outline to it, is the first part of the interaction with the patient. So yeah, so this is sort of a magnified version, and this is the bit I think we've got our biggest challenge, if I'm being honest. So this is the bit where if a patient presents themselves by walking into a pharmacy, this is where we need to make sure that our counter assistants or dispensers, whoever's representing your pharmacy on the sales floor, in the dispensary, in the pharmacy, knows what questions to ask to evaluate exactly where that patient is in their healthcare journey, to investigate, to see whether they need to see the pharmacist in the consulting room. And with some of the conditions, you may feel that it's beyond, the know-how of the healthcare assistant, and you may have to assess the process within your own pharmacy and maybe introduce the pharmacist a little bit earlier. My word of warning with that is, of course, that if the patient then doesn't fulfill the gateway point, the gateway criteria, you won't get any payment for that patient at all. If you spend half an hour with them, you won't get any payment whatsoever. So you need to be clever with your time and smart with your time to make sure this service remains financially viable for you to deliver. So I think we've got a lot of work to do, and the LPCs will try and help you with that, to try to get our HCAs and other members of your team who are in the pharmacy to understand what they need to do to understand exactly where the patient's coming from in terms of their condition. And then this is the bottom half of the critical pathway. This is where it turns into the consultation within the room, and it gets far more clinical. The questioning becomes a little bit more scientific, I suppose. And there's a lot of red flags built into this as well, in case you need to refer this patient to out of hours, to urgent care, to the GP, or there's another pathway that exists for you to do something with that patient. But don't forget, at the end of the day, these are all minor illnesses. So we're not talking about, investigating too serious, hopefully, but there's always that chance, isn't there, that a patient presents themselves as something that looks quite innocent and potentially it's a red flag for something else. So this is where the skill really of the pharmacist comes into play, and your fantastic knowledge and experience working in, many of you in your pharmacies for years and years now. So in terms of the PGDs, pharmacists need to read all 23 PGDs and the protocol. And don't forget, this will include your locums as well. This is where, and we've got another challenge. The CPE published draft PGDs in December to help you, give you more time to look at them. But you must read and sign the final versions rather than the draft versions. The draft versions aren't signed by anyone from NHS. So make sure, and I put the link on this slide, make sure that you've signed the final version of the PGDs. And I would, I think with the whole thing we've got here with Pharmacy First, I would make a binder and put it in your consulting room with all the PGDs, all the clinical pathways, all the flow charts, everything you need for reference, because nobody is going to be able to remember what's in all these PGDs. And when you start reading them, the amount of detail in there, the exemptions, the warning signs, there's quite a lot of them. So I would actively encourage you to have these ready to hand in your consulting room. Okay, in terms of learning and development, we've talked about what you need to do. There's quite a lot out there to help you, you'll be relieved to know. So CPPE have been commissioned to deliver face-to-face training. You may have seen they filled it rather quickly. So we have a plan B as an LPC, be pleased to hear. But they've also published lots and lots of resources on their website, lots of e-learning modules. They're creating some video modules. And they've also produced a really, really useful document, the self-assessment framework, which is basically a checklist for a pharmacist who can check their competency and confidence around delivering the service. And there's links then to nice guidelines and all the things that you need to make sure that you feel comfortable as a pharmacist in having a conversation with a patient around their condition. And then there's also a personal development action plan on their website as well. So I'm just checking the waiting room. I thought I saw someone waiting there. No. Okay, next slide. Clinic Skills have also been commissioned to deliver some training as well. They've put on a couple of online webinars. I believe there's one next week, but it's been full now for 3 or 4 weeks. So we're asking them to deliver another one. And again, they've also got lots of resource on there to help you, with your learning, a lot of e-learning modules. And Community Pharmacy England have actually put together a couple of webinars. One was before Christmas and it's been recorded. It's on their website. And they're doing another one next week. A similar one to this, but obviously this is a more local one. But a lot of the information will remain the same. And then the LPC is doing a lot of work in terms of training. We've actually laid on 3 evening engagement events. 2 of them are full now. We've only got places left in Oxford. We've laid on ENT training in Frimley for Frimley contractors. There's still 15 places left for that. And we're just waiting to finalize the date, but hopefully end of February, beginning of March. We've got another 120 places now that we've got Bob ICS to pay for ENT training. So the Frimley one's going to be rolled out by CPPE and the Bob one's going to be rolled out by ECG. And the ECG one is 1 hour and 45 minutes. And they give you a 3-hour e-learning module on Pharmacy First, the 7 clinical pathways. And for your ENT training, you actually get signed off and sort of assessed your skill set around using an otoscope, which is really useful. But we've also, as an LPC, commissioned, and we have done now, worked with Virtual Outcomes for 4 years or so. You've all got access to virtualoutcomes.co.uk, where there's dozens of online modules where you and any of your team can go in and follow the module. It gets recorded. You can print a certificate. It's all done by a community pharmacist who lives in the Southwest. And it's absolutely brilliant. And I do it myself, and I just get an overview of a particular service, and I find it really, really useful. We're just waiting for the Pharmacy First ones to be put on their website this week. I had a look at the lateral flow device test one last week, And as you can see, there's like, it's almost like an audio visual module they go through. And then they also publish all the resources that you need to be able to deliver the service as well. So access to the service specification, NICE guidelines, etc., etc. So really, really useful resource. And that's been paid for you already for the rest of the year. All you've got to do is go into the website and put your ODS code in, and then you can get all your staff to register individually, and it'll keep a record of all their training. So really, really useful resource. So in terms of preparing to provide the service, and I've touched on some of this already, make sure you've read the service spec and the pathways. Pretty obvious, I think. Sign up for NYS if you want to provide the service. Hopefully most of you will. Make sure you've got an otoscope on order. Now I've had lots of requests for recommendations. There's lots of companies selling them. They're on Amazon for £35, or you can spend over £300. It's a personal preference thing. Download, read and sign the PGDs in the clinical protocol. And you can see here the PGDs sort of outline exactly what medication is assigned to each pathway for you to dispense using the PGD. You need to make sure you've got your IT system in place, and hopefully your provider's already had that conversation with you around what they're doing. So it's one of those four, you'll be fine. There's a briefing document for your staff I put a link into that CPE have produced, because you've really got to get them on board as well in your pharmacy. Make sure you've got a training plan for all your pharmacists using the self-assessment framework, and make sure they've had the training if they need it. If they don't need the training, don't forget it's about competency and confidence. If they already know how to use an otoscope, then that's all they need to do. They just need to declare that they're confident to use one. And then keep checking back at our LPC website for any more local training sessions that we will lay on. And you also need to obviously develop your SOP for your pharmacy as well. There's a couple of resources on the CPE website. There's 2 checklists, one for owners, one for pharmacists. There's the CPCS toolkit that's being updated. And don't forget, like I've said before, you've got CPPE and Clinic Skills web pages to help you get access to loads of learning development, and the briefing for staff is on the CPE website. And this is just a screenshot of the checklist. It's really, really good. I've been through it myself. Just a tick box exercise, but it gives you that confidence that you've done everything you need to do to help deliver the service. And in terms of promoting the service, so we've talked about you need to do 1 consultation in February. At the end of February, you're going to start to see some comms come out from the NHS, and probably locally as well, starting to advertise the service. So a marketing campaign is starting to be put together. The LPCs are speaking to LMC, GPs, secondary care, whoever, to make sure they understand the service as well. And we're working quite closely with SCAS, who is the provider of the 111 service in Thames Valley. And then there's more and more resources being developed by CPE, which will appear on their website in due course. And that's it. So do we have some questions, Kevin and Robert?
So we did have a couple of questions. Yeah, just hold on. I'm just trying to get the.
Yeah, let me just stop sharing my screen.
Yeah.
So I can see you all. That's better.
So the second one was about from the UTI service, which Inc has picked up. So I mean, it's done. It matches what CPE said, that any local services that overlap would be sort of wound down.
Yeah, and that is being wound down. So that's the right thing to do, I think, because the national service takes precedence now. But what we are doing is we're speaking to the systems and asking whether we can divert the money that was used for that into something else for our patients within the system. And I don't know whether you've seen it, but actually we've had a new minor ailment service signed off in Bob for those that are on low income, and that was rolled out just before Christmas. And that's part of the ambition about the whole self-care and pharmacy first agenda. So for those patients that are referred to you by a GP that needs an over-the-counter medicine who can't afford it, they can now get it on the Bob minor ailment scheme. So make sure you've signed up for that. And that should just be on your farm outcomes template if you want to sign up for that.
And the other question was from Fiona Wyborn, asking about the length of supply for antibiotics. I mean, I'm guessing that's the 5-day course.
Yes,
It's
it's
more
5
to
days,
do
I believe.
with,
Yeah.
more to do with NICE and the AMR requirements. I mean, there will be some pack splitting and there will be the dispensing process, so worth thinking ahead on that. I mean, you get some money up front, so it will be worth looking at
it's
what
definitely 5
antibiotics
days.
you've got.
But I can pass on the feedback around splitting packs and reimbursement for that.
I think we should. And also, I seem to remember from reading it, there's no broken bulk because it's not under the existing dispensing. It's based on Part 8 of the drug tariff for pricing, but not for the other bits. Is that correct, David?
I think so. Yeah.
There's no broken
Absolutely.
bulk for this, but they're only small amounts of hopefully lower price antibiotics. But I guess if you're having any issues, feed them straight back in terms of availability as well.
Good. I'm just writing down the questions as well.
I kept a note of that one.
Yeah, that's a good one, actually. Yeah, so Yinka's reinforced what we said around the UTI service. Yeah, there are a lot of PGDs to go through, and 23 is a lot, isn't it? I mean,
well, I was going to say that from my experience of using, say, something like travel, where you've got a lot of PGDs, is to keep as much open on your screen as you can, even when you're in the consultation. So don't necessarily rely on the paper copies, and also the most up-to-date ones online normally. So certainly in the early stages, use the IT that you've got to refer to as you go along. That would be, and also use that checklist that David mentioned from CP for getting ready.
Absolutely. Yinka.
Robert, you've actually kind of stole my thunder there. You did exactly what I was thinking.
I didn't steal your dinner, just thunder.
That's all gone. That's absolutely
okay.
Completely. But I think that's actually, I mean, there's a lot of information, there's a lot of PGDs, and back in the day when I used to do a lot of PGDs, I had all the information up with me. So don't feel you have to know it all off by heart. It's absolutely okay to use all the resources in the checklist and kind of work through it with the patient in front of you, and that's okay to do that until you get used to doing it on a regular basis. Use the material.
Exactly. Thank you for that. Just had a question from a locum about signing paperwork in each individual pharmacy.
Hi, Sahela. How are you doing? You okay? You there?
Now, I believe it depends on who employs you, but I believe that the proper answer is that you should have a signed copy in each pharmacy. But we're waiting to hear what Boots are doing, I think, because they don't normally.
It used to be by superintendent, didn't it? Because the superintendent used to sign you off as competent. That's like the flu one, so that works for a group. But if you've got certainly your regular pharmacies, you should be looking at signing it, I think.
So we've got Corinne on the line, who owns quite a few pharmacies. Corinne, are you able to interject there? Can you confirm what you're asking your locums to do?
Hi there. Well, we're going to do like a DocuSign so that they will sign the, not like necessarily as paper, but through the internet, etc. And in that, we'll have listed as an overarching company as opposed to per branch.
Yes. Yes, good. Okay, so Robert's right then. So it's by superintendent. But you can choose, can't you, to have one in each branch if you wanted to. So it's your decision. Thanks, Corinne. That's really useful. Thank you very much. But Hatim, feedback should be given that the PGDs we have to refer to should contain with them relevant links that we will need. Yeah, I agree, but the PGDs are quite an old-fashioned document, aren't they? They're quite formal. Yinka, I don't know whether you want to.
In the service spec, I don't know.
So things like fever pain.
I think it's more of a convenience thing, isn't it? That, because sometimes if you don't know, like if you've never heard of it, then where do I find that information? You've got a link that takes you directly there. So I totally agree with you. It would, for convenience, used to always have hyperlinks. The only thing with hyperlinks is they sometimes stop working because the links change. So every time you have to update the document, you have to update all the links. So that's why people tend not to put the links in, but it does make it more inconvenient.
Yeah, I mean, you're going to have to sort of go through the clinical pathways with a fine-tooth comb in terms of. We've had this discussion at committee level, haven't we, Robert, around extended WAM questions for HCAs. So we introduce an extra H for CPCS about have you been referred, but you may want to expand on a couple of other ones as well around just finding out more from your patients about their condition.
That's right. Try and just give them the basic tools on the counter to help you with that.
We've had a question from Ava around geography and where is Bob? Well, Bob is West Berkshire, Berkshire West, Buckinghamshire and Oxfordshire. So I'm afraid it doesn't cover Frimley, I'm afraid, Ava. But we're working on Yinka, don't worry.
He truly is. He truly is. Not giving up on one for Frimley.
So any other questions from anyone? No, a very good turnout. So thank you for coming this evening, giving up your precious time. Hopefully some of you are coming to our face-to-face events as well. So I'm gonna bring James in now. So our deputy chair, James Famikin. Calling James. Where is he? There he is. Now, I'm not going to embarrass James, but he runs a very successful pharmacy in Farringdon in Oxfordshire. And I believe, James, you have quite a lot of consultations at the weekend, but tend to come from the private sector. So this will be hopefully quite useful for you to get that extra income from those that can't afford going through the private route. So have you had time to go through some of the paperwork here? Does it make sense to you in terms of what you've been delivering already? You're on mute. He's lost. You got it, James?
James, if you hover over the microphone and press the space bar, it often unmutes you. By pressing the space bar, does that unmute you?
No. Do you want to come back when you can, James?
Yeah.
Oh, there he is.
Sorry. Yeah, it makes sense. Yes, absolutely. It makes sense to me. I've gone through them.
Yeah, and so in terms of the 7 conditions, you think they're good ones that you can work on and they're the right ones for patients?
Yes, it is. Absolutely. Yeah. I'm actually familiar with them, to be honest. Because I've used them as independent prescriber in urgent care centers, and so a lot of them just when I look at the PGDs, is something that I've clinically done. So it's very, very good. Very, very good.
Fantastic. Good.
James, can I ask you a quick question? How have you prepared your staff for the Pharmacy First service? So your support staff, what have you been doing to get them ready to support you to deliver?
I mean, those training, I've gone through the training of each pathway with them. They list all those things. In fact, when we started the GP referral service, I think now that although I proactively have been the one doing it because of my clinical skills, but now that we have pharmacy services, I've trained each and every one of them on take each component of those pathway and go through with them one by one to see what can be done, ask knowledge, because first of all, I just want to know their underlying knowledge. What do they know? Just test their basic skills, especially the local pharmacies that work with me. I have 2 regular local pharmacies that work with me daily. So, and some of I just wanted to understand their clinical skills, their understanding of the service. We form a WhatsApp group where if there is any question, I provide follow-up trainings and with them, and I raise if there is any question, they bring me back to me. I've already created templates and templates for everything for them actually in my pharmacy. I've created a folder so that they can have a look at it if there's anything, or I've printed all those things, and I've already various conditions as well. The safe netting advice, the clinical conditions, and all those things which I've already prepared for each one. If there's any queries, and so that's what I've done at the moment. But there's still a lot to do in terms of progressing forward. Anyway.
Thanks, James. It's really helpful because I think that's a really key part, isn't it? It's making sure that your support staff are really upskilled so that they can sort of do a big bulk of the upfront work to release the time so you can focus on what only you can do. So getting that right, and it's going to be a new sort of way of working for some of our support staff that haven't maybe necessarily been involved in any kind of services in the past. So it'd be good to maybe share as well, David, next, as you're kind of going through these sessions to kind of understand what people are doing as we get nearer and nearer to launch, share some good cases and stuff.
Because it goes without saying, this is a really, really important service for pharmacy to deliver. This is the most money we've been given now for, 20 plus years in one go, Robert? I think it's, it's not an enormous amount of money, but it is, isn't it? It's because anything more than zero is a lot for us because we've been used to that. But it's really important that we show everybody else in the healthcare sector what we can deliver and what we can do. So we have to do it properly. We have to do it safely. And we have to do it, with the patient at the center of everything that we do. Because if we want more money, this money we've been given run out in a year, 18 months. If we want more money, we have to give them a reason to believe in us and to, use community pharmacy for the skill set that it's got. And this is the pathway to the future now, isn't it? So I'm really pleased we've got this extra funding to deliver a new service, but we do need the help of all the pharmacies across England to do a great job of this. So we can't underestimate how much work will be needed to get this up and running. And I think the pricing framework, the reimbursement framework, is actually quite good for us. So to have £1,000 a month just to be there for that service initially is a really great idea. And then once you get used to delivering your 30 a month, by the time we get to October, that comes up to £1,450 a month in income, which you wouldn't have got last year. And basically some of the work you're doing already for free anyway. So and it's a great opportunity, I think, to relaunch the whole referral service with our GP practices. I think a lot of them got a little bit jaded with the whole Lloyd situation where they were closing on odd days and not really trying very hard. But all those pharmacies now have been bought by brand new owners who are really enthusiastic and, want to do the best for the local community. And the IT pathway is much, much improved. So we've talked about the £20 million that's going to be spent. The notification from your platform will go straight to the GP practice, and eventually, hopefully in the next 2 or 3 months, we'll go straight into patient record as well, which is brilliant for us. We've been asking for this for years and years and years. So that takes away all the concerns from practices around information and data, and it goes straight to the patient record.
When does it go live? The IT part. When does that happen?
It's supposed to go live on the first day of the service. My personal opinion will be most of it will go live. So it will send the message to the GP, but it won't write into the record for another 2 or 3 months. But
That's
the
what it said,
GPs will
wasn't
get
it?
a
Yes.
notification through.
They'll get it. They can review it and add it. can't they?
DocMan, yeah, wherever it's called, yeah. But
So
that's
it's
great
not-
because
it's
it
not for urgent.
endorses the quality of the work that you'll be doing. And this is where it becomes important that actually when you do have that consultation, your recording is really accurate and concise because somebody else is going to read and review. So no other or, unknown. It's got to be specific. This is great for the patient as well, of course, isn't it? Fantastic.
It's great for us as well.
Yeah.
Absolutely.
It is.
Absolutely. And I know all of you are looking at your businesses, looking at ways which you can change processes within the pharmacy to release pharmacist time. And this is the sort of thing that you want to have your pharmacists available for, to help deliver. And it's great to have Yinka on board here as well, because don't forget, we've also got alongside this the independent prescriber pathfinder sort of, I can't call it pilot, can I, Yinka? Sort of
Pathfinder program.
Yeah. So we've got three pharmacies in Frimley? Three, yeah. Who are going to be running an independent prescribing sort of pathway as a test bed for the next few months, testing out different types of IT and the whole process. Because eventually the 23 PGDs we've got from the 31st of January will turn into prescribing opportunities in, I can't say how long, maybe a year, maybe 2 years, which is why we need to start encouraging more pharmacists to become independent prescribers, which I know is easier said than done, but it's the future. We've got a question actually from Arkna. With remote consultations, how can you prove that it is the patient you are talking to?
Do you want me to have a stab at this?
Yeah, go on, Robert.
So I mean, there is NHS guidance on remote consultations, which probably Yinka will have seen as well. But it's slightly wordy. But basically, you've got to just professionally satisfy yourself, the same as if you made a phone call. So you perhaps might want them to confirm their date of birth, or I mean, if it's your patient, you might even recognise them. I mean, a high quality video takes a bit of organising, to be honest with you. So if you're going to do that, you need to think about what platform you're going to use, and and part of that will be the ID. So you'll need to make sure you can look on their basic summary care record to get some contact information as well, this kind of thing. So it's up to you as a professional to establish the person that you're talking to. I mean, you might be talking to the parent anyway for an under 18. So it's just like any situation, use your best judgment.
Yeah. Hello.
Hi, James.
Yeah, just to buttress the point, CPP has training on remote consultation. Look at it, and I do remote consultation with 111 virtually every other week. So at least, if you need any help, I can send some information. I've been, I could tell you how to safeguard. I mean, there are basic things if you cover their name, their date of birth, sometimes their address, the address as well. Those are the basic fundamental things that you need to, and you give them you ask for the permission to go into, sometimes maybe you want to go into their summary care record. You can see some other information that you can ask them that will consolidate the information you have got from them. So yeah, I think it's pretty straightforward. Yeah.
I think there's one more question come up, David, about onward referral and escalation. The farm outcome message is just going to go in document, and it's not for urgent referral. You still need to use your existing method to contact the surgery, won't you? Same as you do for the two parts that have been amalgamated into this. Yeah,
exactly. There's no change really with the existing service. You still need to, and that's it. I suppose it's all about having a great relationship with your GP practice, is to make sure you have got those lines of communication, that you do know their back office number. And if you're in the same building, make sure you've got that relationship that you can just pop next door and have a quiet word with the receptionist or the practice manager. It's important to build up those links. Oh, thanks for the link, Yinka. It's great.
Yeah. Just make that. Look, there were so many people on the call. It's great. It's like a sort of 100 to 1 LPC version. I've never seen so many people. It's really, really good. Very, very encouraging, because if we'd had,
there's been a lot of interest in this.
I'm so glad people want to learn how to deliver it. And just the other thing is, I would stress again the virtual outcomes training. packages which are free, which would support it for you guys and for your staff as well. But,
Absolutely.
a big thank you from me for attending.
Yeah, thank you very much. Hopefully we'll see some of you at our face-to-face events. We've got
Bring your
High Wycombe
ears.
next week. We've got nearly 70 people going to that. We've got 50 plus going to Reading, and like I said, we've got a few more places for Oxfordshire. And I'll drop the date of the ENT training for Bob as soon as I get the date back from Amanda. She's got to confirm the hotel and the trainers for that. So that'll be hopefully end of Feb, beginning of March.
Yeah.